So just a reminder, we are a monthly webinar series. We're on the fourth Tuesday of the month, held at 10 a.m. Pacific time. And our webinars have been ongoing since January, and we have 2 more coming up in both June and July. And our format for our webinars are a 25-minute panel presentation followed by peer facilitated discussion. And so we are excited about our next 2 sessions, which are addressing stigma in a community and learning collaboratives as a dissemination mechanism. So we will provide you with some information after this session so you can learn about how to join a future session. So again, thank you for being here today. Next slide. So here's our agenda for today. We're going to start off with some brief introductions, and then we'll move on to a panel discussion, and then we'll have some time for group discussion through using the breakout feature in Zoom, and then we'll come back for some sharing time. All right, so this is the 6 Building Blocks team. We're the 6 Building Blocks team, and a little bit about us. We're an evidence-based quality improvement roadmap that helps primary care teams and clinics make system-based improvements that support guideline-driven care for chronic pain and patients on long-term opioid therapy. If you'd like to learn more about our work and additional resources, please visit our website at improvingopioidcare.org. And this is a little bit about our team, Doctors Michael Parchman and Laura Mae Baldwin, and then the team of practice facilitators, which are joining this call today. Next slide. So now we want to hear a little bit from you. We're excited that this is a national webinar series, and we'd like you to help us understand who's on the call today. So what I'd like you to do is use the Annotate feature in Zoom. So if you go to the top of your screen, there is a little button that says View Options. And if you click on that, there's a drop-down menu that says Annotate. So if you click on Annotate, you're able to either stamp or circle the state that you're from, and that way we can just get a nice spread of all the locations. And great. So it looks like we have a number of folks joining us today from all across the country. And also in the chat, it's really helpful to not only just see on a map where you're from, but if you could write your name, organization, and maybe where that organization is located in case others would like to follow up after the call. That's great. We'll just wait a few more minutes here for everyone to make their selections. All right, so I think we can move on to the next slide. Thank you everyone for helping us do that. And now, all right, we can move to the next slide. And Michael, Dr. Parchman will be introducing our panelists today. So I'll pass it over to you, Dr. Parchman.
Hey, thanks, Ashley. It's great to be here. It's great to see all of you, some of you again. Thanks for joining our webinar series. I am really excited today to introduce to you 3 individuals who we've invited to join us today for sort of a conversation about tailoring programs to the needs of rural communities. Let me just introduce them briefly to you. I'll let them tell you a little bit more about themselves. Caleb Holzer is a rural family physician. He provides full spectrum primary care in his rural community. He's also the site director for a family medicine rural training program out of Spokane, Washington. I think more relevant to our conversation today, he is the physician champion for population health and the Tri-County Opioid Treatment Network, which is a hub and spoke program in Northeast Washington with Providence Northeast. We're just really thrilled that Caleb could join us today. So Caleb, thank you for joining us. The second panelist is Peg Gehring. Peg is a family nurse practitioner in Idaho. She's been in the north central area of Idaho really since, I guess, about 2009. She recently completed a doctorate in nursing practice, and the focus of her thesis was on managing chronic pain in the rural setting. And she's been treating patients with chronic pain and opioid use disorder in her practice. She completed her ex-waiver training for buprenorphine in 2019. And she's been working actually on several different initiatives that have been funded by the CDC and others nationally as a learning collaborative, and is currently the champion for her rural medication for opioid use disorder program in the state of Idaho. And last but certainly not least, I'm just thrilled that Laura Lewison is joining us today. Laura is a public health social worker in North Carolina. She's been working in the area of implementation of behavioral health, maternal and child health, early childhood programs for over 20 years, and is currently the Associate Director for the National Implementation Research Network at the Frank Porter Graham Child Development Institute at the University of North Carolina. But really what we're really excited about her joining us today is that she has been working with a number of organizations in past years about building capacity for public health systems and especially in rural communities. And we're just thrilled that she could join us today. Caleb, could we thank you for joining, Caleb. Could we start with you and really as you all visit with us this morning, each of you, we're interested in sharing with us what you think is important to consider when adapting a program to a rural setting, because a lot of people on the call today have programs that are related to opioid prescribing, programs that are related to opioid use disorder treatment, and are interested in the rural setting and what's unique about it and how do you adapt the program to a rural setting. So Caleb, can you tell us a little bit more about your role in your Hub and Spoke program to start off with?
Yeah, thank you, Michael, for inviting me to be here. That's great. So I'm up in northeastern Washington, and our Hub and Spoke actually covers 3 counties. We received funding about 3 years ago now, and I think that's a kind of a unique feature about where we're at, is just the geographic area is very large. And we originally received funding and had only 2 counties involved, and since that time have expanded it to the 3 counties area. And we've rebranded it the Tri-County Opioid Treatment Network because it's sort of more of a network than it is a hub and spoke so much at this point. And we have a lot of different kinds of organizations involved that are partners, and some of which have not worked together previously. So this has been a really great collaborative effort. But we have, as part of our spoke network, I guess you could say, we have 2 different or 3 different healthcare systems. So we have 2 other small rural critical access hospitals involved, as well as the Providence has 2 critical access hospitals. And along with those critical access hospitals come attached clinics. So we have those clinics involved, as well as our rural resources is a kind of a clearinghouse for social services, and a behavioral health organization called Northeast Washington Alliance Counseling, which is a Medicaid serving counseling service, which also does opiate use disorder counseling, but importantly, no medication for opiate use disorder at this point. So we really need it. And then we also have a partnership with the Colville Indian Reservation and the Lake Roosevelt Community Health Center. So that's the southern half of Ferry County. And so we're helping to meet the needs of that population as well. So it's a really disparate group of organizations involving, and then one other spoke I forgot was our Tri-County Health District, which is the public health agency for the 3 counties. And so they're involved, as well as our Stevens County Prosecuting Attorney's Office. So it's a very large network involving, prescribers, clinical people doing clinical medicine, hospitals, social services, and also counseling services as well, and also covers the Native American population. So that's a little bit of background about how big the network is anyways.
That's great. Thanks, Caleb. That's a great description of your program. So have you thought about, in your rural setting, what kind of adaptations have you had to make that you think are a function of the fact that you are in a rural setting to rolling out these programs?
Well, you have to use the resources that you have available to us, and interestingly, in our area, our physicians are actually a source of strength, I think, and that we have adequate physician staffing. We have 13 waivered providers just in Stevens County in our organization and among the network more generally. So the access issue for us really is not so much about prescribing, but about all the ancillary services and the wraparound services that we need. And that may be different than in other areas, but because I think our area is largely served by people like myself, full spectrum family docs who want to just treat are used to doing a lot of things we're not necessarily 100% trained up, specialized to do. We really have centered our network really around family medicine and around primary care, which may be different than I think other networks may do it, because ours is really focused on physicians delivering services, including things like hepatitis C treatment and maternity care and those things in the context of substance use disorder, and then using the wraparound services to really take care of the counseling and the social working and that kind of thing. So we have a different set of resources, I think, than what you might find in an urban area from that standpoint.
Yeah, that's really insightful. I have found that rural family physicians often are willing to take on a more broad role in their community in terms of providing healthcare services, just because they're it.
We're used to doing that in a lot of different arenas, and so this it doesn't feel that uncomfortable to us.
That uncomfortable to you, yeah. So when you talk about the wraparound services that are available, have you found ways to think about putting the pieces of the puzzle together in a way that really does do that wraparound service in a rural setting? How does that happen? Because I know sometimes like geographic distances are an issue, right?
Yeah, that is a huge barrier, and something we're trying to overcome with some incorporation of telemedicine. And we have a partnership with this organization called Bright Heart Health. Right now, we're engaged in a research study to try and incorporate that to help with wraparound services and counseling. And that's been not as successful as we would have liked to have seen, probably because of barriers to internet connectivity and so not just old school sort of infrastructure barriers, but newer school infrastructure barriers are really difficult in our rural area and prevent people from accessing care. But certainly we have a lot of barriers just from transportation. I have several patients, to come and get counseling in Colville, which is the main town in my county where I practice. I have patients driving an hour and a half to 2 hours just to get to see me. And so if you add in a separate trip for substance use disorder counseling and or whatever other needs they have, it gets pretty burdensome pretty quickly to the patient to access all those services. And so it's trying to pare down and use the services, or let the patient decide which of the services that they really need, and not make anything too mandatory, has been a learning point for us. That if they're doing well, we have few barriers to getting care, and they can kind of pick and choose from the smorgasbord of services that we offer.
That's great. Do you try to bundle visits? So you try to coordinate so all the visits happen on the same day, so they don't have to make multiple trips? Is that the kind of thing you're thinking through?
Yeah, we would like to do that. We had, one of the challenges we face is really social work, attracting social workers. When we've been understaffed for about 2 years of our 3 years of funding from a social working perspective. And when we had our social worker in-house at the hub, she would provide a lot of co-occurring mental health counseling as well as substance use disorder counseling. And then that component went really well with a regular primary care visit, say with me or another provider. And we could bundle those, but we have not been able to fill that position for the last year and a half. So that's made things very difficult. So when we're referring for counseling, we use one of our spokes, which is great. It works well, but it doesn't work as well from a care navigating standpoint, or from a patient being able to set up all their appointments within 20 minutes of each other. So that adds a burden to the patient.
Sure. So Peg, let me turn to you. Peg, tell us a little bit about your setting and what your role is.
Well, I was nodding with most of Caleb's statements. We too were in a study with UCLA and tried to adapt Bright Heart Health, and it failed miserably for us. Part of it was that most of our patients didn't have the internet needed to access Bright Heart Health. It simply is not available. Bright Heart Health tried to put tablets in the clinics, but then we also ran into the barrier that patients didn't want to talk to a tablet. They wanted to talk to a real person. Some of the other problems we've had that reflect Caleb's problem is getting the social workers that we need. We too have several clinics. We have 7 different clinics, and the social workers haven't learned to bilocate to be in 7 different clinics at the same time. We do, they can do televisits from clinic to clinic, and that has been the most successful aspect of our treatment program, is that the social worker that we do have is in one clinic. We have a room in all the clinics that they can talk to her. So she can be in clinic A and they can be in clinic C, and they can talk after my appointment. That has been very helpful. But to use a nationally program like Bright Heart Health has been very unhelpful. We don't have the staff to do the legwork, to make sure that they have all their medicine, are making it to this meeting and to that meeting, and now we're going to cut down this much. We've requested an RN, to kind of take control of that program, so that our personal nurses aren't doing all the work, or we're not doing all the work. But with COVID and everything else, finding RNs is difficult. We have lots of open positions. So that has been one of the barriers. Another barrier is, we joke about, you've entered Idaho, please turn your black clock back 25 years. And that's not so far-fetched. That it just, one of the patients that I successfully weaned off opioids, it took me 3 years to do that. I had developed a good relationship with him. Took me 2 years to talk him to even try this program, and we have everything in place with the 6 building blocks, the urine drug screens, we have some counselors, we have all this stuff in place. He even visited with the counselor, but it still took me 2 years to talk him into it. And then when I was actively weaning him off, he called me about twice a day. And that is a very big burden. And they don't like, I don't know if Caleb can back me up on this, but they don't want to talk to the counselor. They don't want to talk to the social worker. They want to talk to their doc about the fact they can't sleep all night, that sort of thing. So it just takes years. I did the UCLA study. We had 6 months, and I think I was in the same study that Caleb was. well, you know, that almost nothing happened in that 6 months. I need 6 years to get these people around. So that's another barrier.
So Peg, what advice would you give someone who says, you know, we've got this program, this, you know, structure of delivering care to patients who have chronic pain, who are on opioids or who have developed an opioid use disorder. We'd like to implement it in your community. What advice would you give them?
Give me social workers, give me nurses that can get the paperwork done.
Yeah.
The MAT trained, as Caleb said, that's not a biggest deal. That's actually the easy part.
Yeah.
You know, and now they're offering MAT training for free. As doctors and nurse practitioners, we take all kinds of training every year to keep up on things.
Yeah.
The MAT training is no better or worse than any other trainings we have to take.
Right.
But we need the backup staff.
Huh. Okay. Yeah, that's interesting. And actually that helps me transition a little bit to asking Laura a question. So Laura, you actually have a white paper about implementing a rural MOUD program in rural settings. And you say that building capacity is sort of the first and foremost implementation need in rural America. What did you mean by that? And what are the implications of that?
Yeah, thank you. Thank you for having me. You know, I think that we see over and over again in our work and implementation that rural communities just require a different approach to implementing policy and practices. And then that approach really needs to begin with building capacity in the people and organizations who live and work in rural communities. And sometimes we think about capacity in sort of an oversimplified way, right? We think, you know, we send somebody to MAT training, they're done. They don't need anything else. Or, you know, that you sit through a couple of webinars and you have the shrink wrapped curriculum on your desk and you're good to go. And the truth is that capacity is really complicated. If it wasn't, we would already be doing it really well. You know, from an implementation perspective, we think about a couple of different kinds of capacity that are necessary for implementing in any context, urban, suburban, or rural. We need people to really understand the innovation or the program that they're implementing. So if it's a new kind of CBT, we need them to understand that and know what the modules are and know the different curriculum aspects. We also need them to have what we call general capacity. And this is something I think that is often challenging in rural communities where people are wearing many different hats and doing lots of different jobs without necessarily an opportunity to specialize. So we may have someone who works as a social worker, but she or he may not have a ton of experience running groups. And so they actually need, in addition to knowing a program, they may also really need some skills in group facilitation that they haven't had a chance to really foster. That's sort of how I think about capacity in terms of practitioners, so social workers or nurses, but then organizations also need capacity as well. Clinics, social service agencies need what I would describe as the opportunity to learn from what they're doing and then adapt their practice well. And so that means being able to use data effectively to look at outcome data, to look at process data for how work is going in your clinic or in your behavioral health setting, and to be able to understand that data and then make changes based on it. A lot of times in implementation, we see that folks are by necessity really reactive. And so they are responding to things that emerge in the moment and don't have the opportunity or the time or the skill to be able to do that kind of proactive planning. And that's really critical for rural communities where we see over and over again that programs require adaptation in rural communities. We don't have a lot of things that are designed specifically for a rural setting. And so in order to be able to adapt innovations that are evidence-based, we have to build the capacity in people and organizations to use information. And that can I think there are lots of practical examples we've seen of how to do that well. You know, I think that means that funders need to support strengthening administrative practices in clinics, need to support training for use of data or for more general capacity skills, not just the innovation. I think funders need to really create systems to support sustaining professionals in rural communities. So both Peg and Caleb talked about being short-staffed and not having enough people. And the truth is that is a perennial workforce problem in a rural community. And so figuring out how do we sort of attract professionals and keep them and grow them. And sometimes it's a grow your own, right? Identifying folks who are maybe earlier in the pipeline and building their capacity to stay. I think that's a huge need in rural work.
Can you talk a little bit about relationship building in rural communities? And it's already come up that sometimes things move at a slower pace, right? And actually, it's one of the things that people love about rural communities. Right? I mean, you know, we leave the big city, we go to the rural area because things move at a slower pace, and you know, but that also has implications for project rollout, right? I mean, in terms of planning and the timeline, they're short-staffed, right? And actually, people say, yeah, just give me the dollars I need to hire somebody first, right? Because there's not enough money. But then there's also the relationship building, and then the timeline to get something rolled out. And you talk about this some in your writings about this, about how you need to plan up front for that time, that building of relationships, and that slower planning for a rollout. And that's unfortunate because a lot of us who apply for grants to get funding do not build that time in up front.
Yes,
Can you say more about that?
Yeah, I think that's exactly right. I mean, I think our typical way of work is to promise outcomes quickly, to rush through the relationship building and the development of trust, both between funders in rural communities, technical assistance providers in rural communities, and then rural communities and their stakeholders. And we often then are very disappointed with the results. We are getting the results that our system is built to achieve at this point. And I think, without approaching this differently, without approaching this from a place of focusing first on relationships and building trust, I think we run a real risk of exacerbating the disparities we already see between rural and urban communities. Currently we already see that rural communities are less likely to implement and sustain evidence-based programming. And our work at NERN, the National Implementation Research Network, would really suggest that that disparity exists because evidence-based and evidence-informed programs are not implemented well in rural communities because of the time needed to establish those relationships and to do what we would describe as ensuring that the innovation or program meets the context. And you can't do that kind of tailoring if you don't know the community where you're implementing. And so, I think I did not grow up in a rural community. And so when I first started to work in rural communities, I was used to working in environments where people didn't know each other, they didn't know their clients intimately, and that in rural and frontier communities, relationships are deeply intimate. You know your clients by name, and they are not just numbers in a medical chart or in your outcome data. And I think that lends a really profound sense of both need, right? The need feels greater, but also there's such potential for leveraging those relationships, using them almost as a spark plug. And so I think, we see over and over again, our data shows that effective implementation really draws on those networks of relationships and that they take time, right? We don't become colleagues working in partnership immediately. And so investing that time up front absolutely has payoff. I have a rural colleague who talks about it as it's the pay now or pay later with interest investment. And I think that's very true for anyone who's working in a rural setting.
That's great. That's really great. Laura, I really appreciate that insight. Ashley, how are we doing on time?
We have about 5 or 10 more minutes.
Okay. Can I circle back to Caleb and Peg and ask, just from your experience then, about this issue? I've observed, this is just my observation, that a strength of a rural community are the relationships that are there, that people know each other, and people know where there are resources, and people know where there are not resources, and the context there. Can Peg or Caleb, can you talk a little bit about relationship building, what that means in your community when you're trying to do something new or roll out something new?
Well, one of the things, those are very good points. I think the other thing I'd just point out briefly is that one of the other things that makes working in rural communities difficult is that all rural communities are pretty different. Even though they're all rural, there's a lot of, so when we talk about designing a program for a rural community, it's sort of, I think it kind of diminishes the idea that actually you're designing it for a lot of different geographical locations, a lot of different cultures. And so that right there in itself makes things more difficult, right? Because it's just not the same thing, even from this county to the next county. You know, my rural is different than, you know, some other rural somewhere else. So I think just acknowledging that there's a lot of variation among rural. And so it makes it hard to say, well, this is the one solution that works in the rural context. But having that ability to sort of give the basic outlines and then let people freeform or improvise with, these are some concepts that seem to work pretty well, I think is a good way to think about rural program implementation. But getting back to your point or question more about the resources available, one of the great parts when we were getting our hub and spoke network going was the sort of lack of multiple overlapping services, which sometimes we think of as a barrier, is that there's not very many services. But the good news is when you're trying to organize people and or reach out to people, there's just one place to go, you know. And in our city, it was like, okay, I have to have a meeting with 5 people, you know, and that gets all the social services, all the counseling, all the hospitals, and that's it. And so that's kind of a strengths-based perspective. It's really actually pretty nice to cut through all that. And if I have a problem, I just call somebody on the phone, you know, and I'm talking to the CEO, you know, which you could never get a meeting with the CEO of a hospital, you know, but in Stevens County, you know, I got them on speed dial. So that's really nice for developing those relationships. So it is about relationships, but in a way, the development of those relationships is a lot easier because there's less barriers to entry. And especially if you're already known in the community as somebody who's looking out for the good of the community, you have a lot of social capital to spend if you spend it in the right way. Some things are controversial, right? Like, so medication for opiate use disorder was controversial in our county 3 years ago. It's less so now that we've been doing this work, but you know, I wasn't 100% sure how this was going to be received by our community. And in fact, we had to do a lot of community forums, a lot of public health work, where I went and presented for the Rotary Club, for the county commissioners, for you know, the AAUW women's group. I mean, I presented everywhere across three counties for like a year to kind of build support for, hey, this is a treatment that works. Let's do it. Let's not have stigma against using medications. And that is a part of this pay now or pay with interest later has, I think, really translated into success 3 years later, because now it's a pretty well accepted form of treatment. And the sheriff now calls and says, hey, you know, we're glad you guys are doing that MOUD thing up there. And, you know, can you see this patient in the prison? You know, so that's some success that took a lot of upfront work to change those perspectives.
That's a great example of capacity building, Caleb, up front, and building those relationships up front. Really, really great. Peg, any thoughts about relationships and specifically about, you know, are there informal leaders in Peg in your community? About how do you connect with leaders in your community, Peg, if you're trying to do something different?
We have connected with the leaders, and the leaders say, great idea, go for it. But then we kind of are dead in the water. What we're finding is most effective is about 5 years ago, we developed a community health worker program. And in every one of our small communities, we have a layperson that is in charge of it. So their most important aspect is they are from the community, you know, that from the community. So they're trustworthy. Because if you're not from the community, you're not trustworthy. That's a rural addendum. You know, you have to have the right last name. And we just started a program. I just received an email from them this morning. I have 9 of my chronic care pain management patients in that program. And they were willing to go because they knew the lady that was running it, even though she has minimal background experience. They have this wonderful book that they just go through. I read through the book a couple of weeks ago. It's probably the best cognitive behavioral self-help book I've come across. And you'd think I'd had the name of that book at hand, but I may have to email it. And they do it as a self-help group, sort of like AA. And one of my patients that is I've been really struggling with, he told me that, yeah, I know Carla, her first name's Carla. I've known Carla all my life, and Carla says that she will help me with this, even though Carla has 0 medical background. And so I'm very excited about that program.
Yeah, relationships and trust. Ashley, I'm gonna thank you, and I just want to say thank you, Caleb. Thank you, Peg. Thank you, Laura. This has been a fabulous conversation, really thought-provoking. And I've seen some interesting comments in the chat in response to this conversation. So thank you so much. Ashley, I'm going to turn it back over to you for our smaller groups.
Great, thank you, Dr. Parchman. All right, so I'm actually going to pass it over to Brooke, who's going to introduce our breakout discussion and some of the questions that we will be talking about. So over to you, Brooke.
Thanks, Ashley. So we are going to break into smaller groups now so that we can have time to sort of process what we've heard and also share good ideas. So our aim here is that these are really productive discussions that will lead to learnings that will help you with the work that you are doing in your state. And we're also going to be coming back and sharing ideas with a larger group. So on the next slide, you'll see the questions that we will be discussing. So we're going to be talking about what, if any, programs your state has adapted for youth in rural communities, and what's been really successful about those programs that others could learn from, and what challenges do you face? What questions do you have for other programs that maybe they have experienced similar challenges and might have ideas of ways to test overcoming those challenges? And if you've not worked in a rural community, do you have any questions for those programs that do work primarily in rural areas? And was there anything you heard in the panelist discussion that you think you might be able to test out and implement when you go back to your work, and how might you bring that to your work? So that is what we're going to be talking about today. And be prepared when we come back. We're
Returning now. So thanks for the small group discussion time. In the last 5 or so minutes here, I'd love to hear about your group's discussions, maybe points of connection with one another in the chat. So if you could list maybe one thing you found interesting within your group, that would be wonderful to share with the rest of the group.
This is Maria, and I was in group 3. We had a really rich discussion about building relationships between law enforcement and harm, those that are seeking to push harm reduction forward, and that I think everybody agreed. You know, we are all community members, but there is that foundational issue of destigmatizing drug use and trying to build those bridges. And the issue of who is allowed to carry naloxone and who isn't was something that came up. Victoria Troger from Montana talked about first responder, a master trainer program that they have worked on, and the challenge of recording data around use of naloxone or incidents was really, to me, very inspiring, the work that has happened there. And then just the issue of finding Alex Dahlquist from Minnesota talked about finding the community within the community. And that just takes time.
Thank you for sharing, Maria. That was so wonderful. Yeah, the community within the community, I definitely can see that, having grown up in rural areas myself. From the chat, we have several great ideas. So transportation issues, dilemma of volunteers, clinician champions are critical for building buy-in among providers, finding local leaders and making sure that they can make a program of their own. Being aware of building trust, each community being different, and finding those key people within the community who are trusted to work with. Again, using peer support specialists. And then let's see, Sharon's group says transportation is often a barrier in areas that are so spread out. People discussing offering home visits, gas cards, bus cards. And telehealth has been tried, but not everyone has internet or phone access. And then Dr. Parchin saying microgrants to build community capacity. Great suggestions. Is there any other team leads or facilitators who'd like to share, or anyone else? Let's see another chat. Developing rather than adapting programs for rural areas. It's a great comment. Laura May, would you like to speak more about that comment about developing?
I think Catherine could do a better job of that. Catherine, do you want to speak up on that?
I just used an example from New Mexico where we've seen better success with education and language programs that were designed in Spanish versus created in English and translated. And I just suggested that I see parallels with working in urban things that were designed, say, at UCLA versus things that were developed in rural areas. Although I definitely also appreciate the panelists' comments about that, and especially Dr. Caleb's comment on not all rural areas are the same. In New Mexico, of course, we have colonias along the southern border that are very, very different from the northwest corner, which is largely communities around the Navajo Nation, just to use a local to me example.
Great example. And thank you for bringing that to this conversation. Let's see, Alex says, recognizing the different approaches between the medical model and the public health model for prevention. Elizabeth says, connecting with your healthy food access coalitions, which can also help with spreading information about your programs. That's also a really great idea. Let's see here. Oh, and she goes on to say that they have a community garden coalition and that you're able to reach a lot of people that way. So many innovations here. Excellent. Well, are there any other comments? Otherwise, let's move on to the next slide. All right, and thank you everyone again for attending this webinar. We're really excited about our next one, which is addressing stigma within a community. But in the meantime, if you could also please click on the link in the chat. It's a 2-question survey that allows you to give feedback about this session, and we use that to help improve future sessions. So again, thank you everyone very much for attending, and we look forward to seeing you at a future webinar session, and we will send out key learnings from this one shortly. So have a great rest of your day, and thank you again.
Thank you, everyone.
Thanks, everybody.